This is Dr. Ahsan. He's joining us to talk today about global oncology and cancer epidemiology. He's the Dean of Population and Precision Health in the Biologic Sciences Division, also the Director of the Institute for Population and Precision Health, and a Professor of Public Health Sciences, Medicine, and Human Genetics. So I will turn it over to him. Thank you.
Okay, thanks, Dan. Thanks for asking me to come here, and thank you all these students. And yesterday I got a sense from Aviva that all of you are almost at the end of year one, and I'm not sure whether any of you had got a chance to take any of the epidemiology course that's offered in the med school. If not, my apology, because I will be talking slightly from the epidemiology angle of the global oncology, because global oncology is so broad, so many things you can talk. Every topic you have gone through so far, you can talk, think about in a global context. So I took the liberty to focus on the aspect that relates to public health and epidemiology. I hope that would be, but I will do it at an introductory level if that would make sense to you. Any problem with that? Any of the students? Then tell me up front, then I'll see what I can do.
That sounds great.
Great, good. So how do you move this slide? Okay, here. So what I thought that I don't know whether you all got a chance to read those 3 papers that Aviva probably sent to you. But if you did, that would be nice. What I'm thinking of, I'll just give you a start with a very brief overview of the global statistics, as I said, from epidemiology perspective. What's the landscape of cancer across the globe, just to give you an overall idea, and then just briefly touch on those 3 papers that I asked you to be distributed, and just to go over the main topics there. And then I will give you maybe last half an hour or so, those of you can linger and stay, then I will give you a little bit of examples of my own research, especially the component within the context of global cancer epidemiology and a clinical epidemiology context, so that it's a little bit relevant to you. So I picked a couple of examples of studies that relates to clinical side of it. So that's my plan. So moving to the overall sense, I'm not sure whether these slides you can see in detail, but you can zoom in your screen and you can look at any component if you want. So this one essentially just looking at the broad, crude total number of cancers, both in terms of incidence of new cancers in a given year, as well as the number of deaths from cancer. On the top 2 pie chart are for overall, and then for men and for women, the second and third respectively. The point here is that, as you can see, about 18 million cases are diagnosed every year. And this is the 2018 data. And about half of them, 10 million individuals die. Not necessarily those 18 millions have died, because those 10 million that happen, some of them may have had developed cancer few years ago. But any given year, that's about 10 million patients die from cancer, 18 million new cases. And the distributions are similar in men and women, but in numbers a little bit higher in men compared to women, but roughly 50%, about half of them, 9 million and 9.5 million men, 8 and 6 in women, and half of them numbered, are deaths. And majority in the green area, as you can see, those are in the more low resource setting countries, and the blue is Europe and the US on the right part of the purple. So as you can see, roughly 3/4 of the cancer cases and about 3/4 equal fraction of the deaths that are happening in the low resource countries, in general. And if this slides, again from the same paper, WHO report from 2018, shows the top in terms of if you rank cancer incidence, by both for men and women, and rank them the number 1, 2, 3, 4, 5 like that, and the number one, the top ranked cancers for a given country is shown here in the map. So top one is the incidence for in male, and the bottom one is for female. And as you can see, for prostate cancer is the commonest. If you didn't know that, but that's for although each of them are in one gender, top one is prostate cancer is men only, and for the bottom one you can see the breast cancer is for women only, but that is the number one across both genders, at least in vast majority of the countries in the world. For females, definitely female breast cancer is the number one across both men and in terms of incidence, and the prostate is predominantly is the top cancer in the developed world, and some part of the, even if they are even Africa and South America, even if they're in the low resource setting. But in the Asian countries, low resource countries in the Asian part and the top, Northern Africa, that number is, the incidence is lung cancer. Okay, so that as you can see, the point here in the bottom cancer, as you can see, even if I go to the next slide, which shows the similar map, but for death, okay? So the top ranked cancer in terms of lives lost in men and women, the top and bottom respectively. So as you can see, the prostate cancer, which was the commonest in the developed part of the world, are not necessarily the major number one, they're not even the, in the top 5 in terms of number, the cause of death for cancer related death. Now the lung cancer is the number one cause of death in most of these even developed countries. And for female, however, as you can see, the breast cancer, even if it's a highly, I know your previous lecture was, I missed it, but I think Dr. Deepa had talked about breast cancer. Even if it has a lot of opportunities to identify breast cancer early and detect early, and there are good treatments, and some of those benefits are being seen in the developed part of the world, as you can see, the North America and a part of the Europe and Australia and even China, some part of it, you can see that. But you don't see that benefit in the too much in the other parts of the world, the low resource settings, where breast cancer remains the number one cause of cancer related deaths. Okay, so, and the point here is, many things that you have been exposed to for breast cancer, probably by Deepa Shet, about in terms of his screening and other modalities. Some of those, the potential benefit of those, what is known and being practiced here in this country and some of the other developed countries, are still not ready or cannot be exploited well in the low resource settings. That's the point. So that's why the death, even if you take the death number, there looks like that they are the number one cause of death. And by the way, and I'm going to come a little bit later, and one of the paper I sent you, it shows some of the way the cancer relevant mortality statistics are calculated and interpreted. So so these numbers shows essentially mortality rate in terms of the number of death by a given cancer by the denominator is the I'm not sure here it shows it, but some sort of unique unit population size. So it could be per 100,000, per million. So it's standardized by the total population size for that, per unit, whatever it is, 100,000 or 1 million, whatever it shows here. I cannot see these small prints. So the number of deaths per population size, you can see it's, it's quite high in the low resource setting in breast cancers, which is the first number one common cancer they're facing, and they're dying from that cancer, breast cancer. That's something, the point here I'm saying, and I'll bring that point later on when we talk about some of the other papers. This slide shows the projection little bit. This is a little bit dated projection from the same group from the American Cancer Society, but this one I didn't find an updated projection, but I'm assuming it hasn't changed too much. And as you can see, going forward in the next 10, 20, 30 years, the fraction of cancers that will be happening in the world is going to be happening more and more in the low resource setting countries, in the developing, so-called developing and countries, in mostly African, Asian countries. And that's partly because among many other, there's many reasons, but one of the major dominant reasons is that people are aging there, though some part of the country, because of other reasons. Their life expectancy are rapidly increasing there. Of course, life expectancy is increasing in the developed country also, but there is much more room for rapid development in the low resource setting, because where the even some basic improvement in hygiene, basic improvement in lowering some policy can, an infectious disease related treatment availability can make infant mortality reduction, maternal mortality reduction, can cause a rapid impact on the improvement in life expectancy, which is going to happen. That is happening in the last couple of decades already. And that will lead to the increased number of course, they will be facing more cancer. Even so, what you have seen in the last two to three figures, those are going to be much more exacerbated, meaning the proportion of cancers, both in terms of incidence and death, these will be happening more and more in those part of the world. Okay, that's the point here. And this one shows the investment again from WHO is on cancer versus other diseases. And this one they chose particularly, for three infectious disease as an example of where there are some, resource commitment have been, happening in the developing world, and mostly funding from the WHO and other rich countries that goes through the AIDS. They are being invested for HIV, TB, malaria for obvious reasons, because those are the major visible, immediate, causes of death that causes loss of productivity and loss of life, because the mostly young and children and young people die from those diseases. So there's a bigger impact on the productivity and life expectancy. But unfortunately, and when you have limited resource and there is competing causes of that competes for the allocation, and cancer is not on the policymakers' radar. So as you can see on the right side of the bar chart shows that cancer is relatively in the developing country world is receiving very little resource, if at all, for in terms of research, management, and treatment and other care aspects. The point there is, again, what I showed you before. This is part of the reason, why in the the relative impact of cancer on life expectancy, mortality, and economic impact in the coming decades would be much disproportionately higher in the developing part of the world, just because of many on top of everything else, in increased frequency of the cancer causing characteristics, lifestyle, lack of health care, lack of resources, lack of education, physician patient ratio, you name it. And then on top of that is the research investment on cancer related one. So that is part of the point I'm just saying. So on this segment, this is the last slide. In the overview, I wanted to show one more slide around the same theme to make a point. These are the top, I think, about 7, 8 cancers that are, there are many different types of statistics or measures that are used to document the, a country's ability to deal with cancer, manage cancer. I would say in terms of that, particularly from the care perspective and treatment. And this one of such measure is mortality to incidence ratio, which is shown on the Y scale on the left side. So what it shows that if the ratio of mortality rates to incidence rate is lower, and that means it means that that there is effective, given what what is happening, given what the cancer cases are happening, but their ability to control, early diagnose, treat, manage, is that ability is well. But the opposite is true for when that ratio is high. That means that there is very little, if at all, ability to manage cancers in those part of the world. And as you can see here, that ratio is much, much lower in the high income countries, which is in the x-axis, and the ratios are much higher in the low resource settings. Another point here I would make a point. If you look at those few, look at the color coding, the breast, blue, colorectal, cervix, uteri. So those, let's take those three. You can take prostate also for that matter, but at least prostate is a little bit less complicated in that. But breast, colorectal, cervix, they are very well effective early diagnosis, screening, and treatment available that should, if employed them judiciously and reasonably well, then you can make a big impact on the mortality from those cancers. And I'm sure you got examples from breast, some of these cancer before, and I'm maybe for breast also already from Fumi. I saw Fumi Olopade also gave some lectures on this. And colorectal is very well early diagnosis screening test available, and so is cervix, uterine, cervical cancer. But see those three cancers, even where there are effective early diagnosis treatment available, even those, you see the curves are a little bit different, but even then, those also in the low resource setting, they are that mortality to incidence ratio is very, very high, meaning that this potential opportunity based on the knowledge that we have are not realized in some of the low resource countries for those. So that's the point here. Again, it's showing in a different way through these statistics. Any questions from you on any of this overview I have gone through so far, and then before I move to the transition to the next phase? Anybody?
Yeah, feel free to type things into the chat box for Dr. Ahsan.
Okay, please do. I have the full screen, so I don't know that I will be able to see the chat box.
Aviva and I can tell you if somebody puts
please.
Yes, I will alert you, so don't worry. Okay,
good. So that's just an overview of the landscape of cancer, and especially from the cancer survival mortality on that side of it, being seen, since you are in the med school and physician side of, you're going to be a physician. So I chose some of these aspects from that angle. And now I will just talk briefly, and the three papers I gave you, again, from that same perspective. I gave you one paper that shows the common metrics or statistics used for measuring survival and mortality from cancer. Okay, and again, I chose those for a reason, because the statistics relevant for cancer incidence, for example, is relatively straightforward, meaning when the denominator is general population or healthy individuals, and then of the incidences of the health individuals who are cancer-free, of fraction of who develop cancer, that's the essentially measure in a given size of the population over a given unit amount of time. That's how usually the incidence rate of cancer or any disease is expressed. You will be exposed to epidemiology courses if you haven't by now. And that is comparable across multiple populations, multiple types of diseases, multiple types of cancers, or in multiple countries, as long as the basic comparison of the denominators are taken care of. For example, if you compare the rate of breast cancer incidence, let's take that example in Chicago, city of Chicago versus city of Seattle, for example. So you express the number of, say, 1,000 people in a given year, 1,000 number of women in a given year per 1,000 women who develop breast cancer in Chicago versus Seattle, you have to pay attention to the who individuals who get breast cancer more than others. If those characteristics distributions are very different, then that cannot be those comparison. You have to be a little bit careful about. You have to those are the so-called confounders. You have to adjust for them to make the rates standardized to those characteristics so that you can compare. For example, if city of Chicago has the proportion of African American women much higher than compared to city of Seattle, and if the women of African ancestry, they have a higher risk of getting breast cancer, okay, then you will have to, even if you take a random 1,000 person, but the proportion of that 1,000 who are African American women, if that's not comparable, then those rate could be, you cannot compare across two cities unless you adjust for that. But once you do that, so this, at least the age and gender, this sort of characteristics. Similarly, if you compare with Chicago with, say, pick an African city, Nigeria, Lagos, for example, a big city, again, the age distribution of women there versus here, even if you adjust for the African ancestry, would be also very different. Then you have to adjust for the age also there. So as long as you adjust for age, ethnic groups, and common characteristic, that's comparable. Unfortunately, for mortality-related characteristics, when you take the mortality rate, okay, take the same thing, that's the number of women die from breast cancer in city of Chicago versus in Seattle, or in Lagos in Nigeria, for example, then just thinking of age and gender does not do it all. Meaning, it's still there are, because now you would, there are additional extra layer of other characteristics that comes into play that are predictors of mortality, treatment, healthcare access, availability to, insurance status, ability to pay, the ability to buy the drugs, the follow-up, physicians training, characteristics, availability of oncology, surgery, all sorts of other characteristics will influence the survival and mortality rate that beyond the characteristics of the denominator that in incidence you have to do. So that's why I gave that this paper that particularly talks about different types of statistics used to measure mortality and survival. And when you talk about cancer, if you're a clinician, if you study anything, any disease, when you look at the survival mortality statistics and numbers, then when you get exposed to do research and different types of figures, and you will see, you will see many types of statistics, and they are not all same, and they don't all convey the same message, and you just cannot easily glean the conclusion and draw, a conclusion, infer from them so easily, unless you take into deeper look. What's the actual statistics? What is most of these measures are some sort of ratio. It has a numerator, it has a denominator, and you have to, my point of this, giving this paper to you is to expose you to these concepts that you have to pay very close attention to. Forget about the complex statistical methods, but just basic, what's the numerator, what's the denominator, and are you comparing apple to apple when you do? So there are so many different types of survival statistics are shown, and one measure may show that, okay, this looks like very good, another measure also not so good. And depending on which measure you compare across countries, across population, across types of cancer, you may get different inference and conclusions. I just want to expose you to this concept that pay attention, be extremely cautious about when you look at the mortality survival type of characteristics. And I will not go into any more details unless you have questions, but this paper shows the common metrics that are used when for survival mortality. On the left column is an example, as it on this chart, when those are applied to a population level, and the right one is at the level of patient level, meaning the denominator in the left side is the general population. Denominator on the right side of the measures would be the number of patients with a given cancer. And so whether you take the measures, whether you look at the whatever the type of measures, and then there is different way of it showing that here, whether you look at mortality per 100,000, whether you look at survival, 5-year survival rate, or whether you look at cause-specific survival. The next slide has some few more numbers, and a few more measures: cancer prognosis, relative survival, cause-specific survival, probability of dying from cancer, and overall survival. And each of them has very different specific way of measuring them with a different numerator and different denominator. And on the the way to interpret them could be you have to be very careful. So I just want to say that without going into details, because you will be exposed to this more later on if you go into study. But pay attention to this as you look at a table, a figure from a journal about breast cancer mortality, a survival, or a Kaplan-Meier curve, the survival curve, and each of them may be, may tell in a particular context with a particular thing. And before you can compare, okay, yeah, this population has higher breast cancer survival than this population, or breast cancer survival seems like much better than colon cancer or prostate cancer or lung cancer, it's not so, you cannot do it so casually, or as easily as incidence you can look into that, okay? Any question from you if you have read this paper, and then if you have question, you can ask me, we can discuss specific, but otherwise I just want to make this point at this stage for you, since you were early in your career at this, just to pay attention. So I will pause here in case you have any questions.
Come on, guys, don't be shy.
All right, stop me later also. Okay, so I'll move on. So that's one paper I gave you. The two other paper I gave you is again to expose you to the idea of, just so you know, two other concepts within the perspective of cancer, global cancer burden. And one is the paper I gave you. And again, I just took one slide. I put a slide, shows the title of the paper and all the headings and subheadings, Here, again, if you read the paper, my point of this was to show you this, if you haven't been exposed to this topic before, this dissemination and implementation science, and this is shown as a context within the context of the breast cancer perspective. And I chose this paper because you have been exposed to the topics, mostly breast cancer, more than others cancers, it seems like. So I chose that one, but it applies to any other cancers, or any other disease you want to study. So the point here is, I want to make few points, and then if you have read the paper, you may have other questions that you can say. Number one point I want to say that often as you, move more later part of your medical school and research and professional careers, you will be, some of you may have interest in, of course, in academic research. I hope all of you will have. Some of you will have interest in the, in the low research setting, and low research setting could be here in the US, here in Chicago. There are a lot of variability in the access to, in the distribution of cancer causing and cancer determinants, as well as determinants of cancer prognosis and survival, including access issue, as well as, of course, there are stark differences, as I showed you example before, between developed country and less developed countries. So as you delve into some of those, addressing those issues, I saw topics of cancer disparity and other things, and disparity across countries, across socioeconomic status, across income, ethnicity, social class. As you address this, there's a common theme you will see. People will be, they're talking about, okay, okay, let's do research. Okay, so more research is done in the certain, segment of the population. So more is known for that segment of the population, and more solutions can come for those segments of population. And whatever that, so that's usually the trend. And one of the things that you will be exposed to, if you haven't, is that when you see disparity of disease incidence or survival or mortality, then you will see one first thing that, okay, the less is known for those population where the disease mortality and more lives are lost because we know less about them. Less of those segment of the population have undergone all the types of research, modern clinical trials that lead to the discovery of treatment, modern genomic research, molecular research, this precision medicine concept that you will be learning more, personalized medicine as you grow. The less is done, those type of research among populations, obviously less will be known, and obviously the benefit they will be getting less, and that's why that will lead to the differences in their the rates of death, mortality, survival, and all the disparity of different types, and that you'll see. So you'll see it in this country, see in this population in in city of Chicago or other our countries, as well as between this country and other countries, other continents, where resource differences are even much wider. Much less research is done there, and much less is known, so much less they get the benefit out of it. And so that's first phenomenon, so you will know that. And so obviously the immediate urge, a lot of people, scientists like me, others, and you will become interested in doing work in this disparity, global health research, so, and so what these population in those countries, scientists in those countries, they're interested in doing research. But then, so one thing is, if you don't know anything, of course, you have to do something. And second is, it's not that everything that is done in one population needs to be replicated in the other population. So that's my point here. That's part of this paper's point, that just because so much is known on the every aspect of biology, genetics, the who, and any aspect of clinical treatment, therapy, everything does not need to be replicated in every population for the other populations to get benefit from. So that's the other side of non-personalized medicine. So one aspect of it is, you will hear that certain type of discoveries needs to be replicated in the another population in order for that population to get benefit from. And there will be many examples of that. I'm not going to that, and you will learn that throughout your career. And that's why the personalized medicine idea comes. So you have to learn for that segment of the population everything in order for you to do something for that. But that's also not necessarily true for everything. There are many research discoveries that even if that is not done in those populations, they can reap the benefit from that. And that point here, I want to say that this paper is this dissemination and implementation science, and the example of global breast cancer control, I said it. So the point here is that there is one body of research that's called the dissemination and implementation science research. What it entails, if you read this paper, is, so you have seen that things that and if to the extent it applies to another population, if you can apply it well, and if you can scale up, and to the extent the second type of the finding that relate to it, if you can do it well, apply it in an effective manner, then you can make a huge difference. And I will give you the example of breast cancer. You saw the first figure I showed you. Even if the breast cancer, there are quite a bit of known about its early diagnosis, biology, treatment is well, there are good treatments available. But even if though we saw that that's the number one cause of death, even in the low resource countries, they're not getting the benefit. Again, here the example is that, you don't need to replicate everything there. You need to replicate you need to do research in the area of dissemination and implementation science. And the researcher in those days, developing country also, instead of being fascinated to do genetic research and do huge genomic research or doing huge clinical trial to see whether certain hormone replacement therapy works or a HER2 inhibitor work, or MRI scanning needs to be, you don't need all of those in replicated there. Rather, type of research needs to be done how, to the extent that can apply certain parameter there, certain therapy, certain modality of early diagnosis, screening, testing, and also the behavior, health, lifestyle, how those could be learned well and scaled up, implemented, and the stakeholders, meaning the patients, general population, the non-government agencies, NGOs, government, international, and policymakers, how they could be educated and appropriate policy is put in place so that the benefit could be applied to those population to make a huge difference, even if you don't do personalized medicine and do personalized medicine research. So there's two sides of it. I just want to make a point. One, you need to learn, do research in all population, to learn something about it, but pay attention what needs to be done and what does not need to be replicated. Rather, you not go ahead and find out what is known, the modality, how can that be applied and implemented and scaled up, in a major way. And the research towards that is important. So that's this paper essentially talks about it. And if you go to the, I don't want to go into the details of it, but there are a couple of, and this applies to the whole, continuum of cancer. So think of this, this slide is they're showing the breast cancer, for example. So obviously a difference could be made at the level of breast cancer risk reduction, in the general population. Then, so that population, those remain healthy, they don't get breast cancer to start with. And the next, breast cancer early detection and diagnosis. But if they do develop cancer, then how can you do the best possible way to detect them early, and then so that they are more amenable to the whatever the known treatment is available. And you have by now know that sooner you can detect and sooner you can, better you can treat. And then obviously, then even if you don't do the early diagnosis, if you miss it, then how can you apply at those, the known breast cancer treatment that is affordable and can make a huge difference in those population. And there's research along those lines. And then lastly is even after all this, you have, if everything else, then in terms of survivorship of once someone gets cancer, get treatment, and then how to get the quality of life and the survivorship improvement again. So dissemination and implementation research is a concept that can apply across all of this continuum. So that's the point here. That's why I'm showing this particular slide, and that this paper has gone into details of different types of each type, the cancer in risk reduction, in early detection, in treatment. Each places are different types of implementation and dissemination research are done. So that's an example I want to show. Okay, so again, this is an example of breast cancer, can apply to any cancer, can apply to any disease you will be dealing with in your professional career later in life. So that's, again, a broad topic. I wanted to make use that you guys, of course, you will be exposed to genomic research, clinical trial, molecular biology process, but this is one aspect. I just wanted to also add to the menu of all the type of research that you are getting exposed to, so that you become interested. And if those of you are interested in addressing health equity or global oncology.
Dr. Ahsan, there's a couple questions in the chat box.
Please.
I don't know if Vivek, do you mind reading your question?
Yes, I apologize for the background noise, first of all. Also, I apologize. I didn't want to interrupt you in the middle of a slide. But Vivek, could you read your question out loud to Professor Ahsan? Or if Vivek is no longer here, I can read the question out loud. So Vivek wanted to ask you, for certain metrics like PFS, how do you know if it correlates to OS for that specific tumor type? And more broadly, how do you know if a certain metric is validated in a given cancer for OS? Do you just need to be on top of the literature or have some metrics better than others?
And PFS, I'm as OS overall survival. Remind me, what is PFS you were referring to here? Let me see.
Progression-free survival.
Progression-free survival. Okay, good. Yes. So, it depends on the context. I don't know whether I can give you an answer based on this question that, what exactly in your mind. So obviously it will depend on the specific context, but you have to see at least the literature that has sizable number of patient that is included in this study, and the major causes of biases have been addressed, so that you can rely on the findings from that study, and then you can then use that for comparison across others. But more specific, it will depend on the specific content. That's all I can say. Dan, do you have anything that you want to, since you have seen them exposed to all other classes, anything else you want to say here that might be helpful to the student based on what they have been exposed to other sessions?
I don't know if I have, just in general, I have to think back to my residency training when we were talking about survival statistics, but tumors like prostate cancer, if you look at overall survival, they're often dying of things unrelated to prostate cancer. So it's kind of hard to maybe interpret, whereas progression-free survival may be more meaningful, whereas something like glioblastoma or pancreatic cancer, the death is usually caused by the tumor itself. So overall survival may give you a good metric for the actual tumor. I don't know if that quite.
Sure. No, that I think.
I would encourage Vivek, if he's still on, or the students in general, there's, you can go to Wikipedia and read about survival statistics, but there's caveats to all these, and there's nuances to what does disease-free survival versus failure-free survival versus local progression-free survival. There's all these different statistics. Actually, something my chair always harps on at our morning conferences with our residents is they'll give a statistic and he'll say, well, what are you actually talking about and what led to that statistic? If we treat it with radiation and they're talking about distant failure, well, the radiation doesn't change distant failure often. Anyway.
Sure, good point. Yes, all the competing causes of, but that's good. I think that's a good addition to the, so I hope that makes sense to the student. The second question, if you go, Aviva.
Yeah, so I'm gonna have actually Ellen read her question out loud. I think it's a little bit better.
Sure. My question was, when talking about standardized and representative epidemiological data, there's often a bias towards high income and data-rich locations. And the only available data in data poor areas are often not representative. How do you feel about using those data with adjustments in order to have at least some kind of comparison across locations? Just when you were talking about making sure that the denominator is the same and that the group that you're talking about is representative of the whole area.
Yeah, so that's a good question. I don't have a very magic answer, but the point is you have to at least think about it. Is there any reason to believe that what you have seen from that one study from in a high income area, or what about the population that's studied well? Is there any reason to believe where you want to compare? That are there any differences that might be affecting the measure of that you are looking at? And that's my. So as long as you pay attention to that, and if there is no obvious reason, then you may have a valid reason to imply that and interpret that. But you just have to pay attention to that. That's all I would say. Okay. Other than that, I don't think there is any magic answer to that. If there is a reason to believe that, yeah, there are the causes, there are reasons, differences in the characteristics that would have an impact on that particular measure differently, and these two populations you want to compare with, have differences in those characteristics, then you have to address those and then figure out how to address that. Any other question there, Aviva, you see? Or no?
No, I think those were the only two for now, but I'm sure they're going to pop up.
Okay, so quickly I want to, so you have the dissemination implementation science exposure, and the last paper I wanted to touch here briefly is the paper that specifically go and zoom into the one particular aspect of it, which is the cancer medicine. and how, and I will not go into the details, but I wanted to again expose you to this, and one specific idea, even, from the clinical perspective, something that you'll be, all of you being clinicians, you will be seeing that what is working, what can make, this outstanding new discoveries that are happening nowadays in the arena of cancer chemotherapy, radiation therapy, obviously, newer way, and newer types of precision medicine, cellular therapy, this targeted therapy, all of those are, but there is a, then immediately the next point is that, can, who this population, whether they have access to all of those, does this therapy apply to their, in order for therapy to be applied there, do you have the basic information? If you want to do the, this lung cancer, there is this wonderful sets of, as I, this targeted therapy, use melanoma, has this immunotherapy, but take lung cancer, take breast cancer, where the HER2/neu. So in order for you to apply the, HER2/neu inhibitors, you need to first make sure that that setting in the cancer patients have the, ability to know whether that person tumor has the HER2/neu expression or not, or the, so if that in a rural Africa, even, there are settings that where they cannot even do this basic, this hormone receptor typing for some of those. So you cannot blanketly, unfortunately, small fraction of cancer patients will have that positive. Some small fraction of lung cancer patients will have the EGFR mutation positive, so that the EGFR mutation, anti-EGFR therapy can be applied. But I have seen, then those therapies are, people talk about why can't you do that? But if it's a small fraction of that population has that kind of mutation in the tumor, then probably it's okay. That's not going to make a huge public health difference there in terms of, because the vast majority, again, I would come back to the breast cancer, vast majority of the breast cancer disparity happens, again, at the point, if others didn't make a point, is not because these personalized medicine of breast cancer are different between these. Vast majority of breast cancer mortality differences, disparity happens because what is well known is this about cancer screening, early diagnosis, even the therapy that's common for commonest type of cancer, hormone positive breast cancer, even those therapy is not being available and given at the right time, at the right type of the patients. That is causing the bigger differences in the, in African countries, other countries where they're the breast, because that's why some of the South Asian countries where the breast cancer mortality still, is high. So let's not forget that, of course we'll pay attention to those modern, therapy, but let's make sure the bread and butter, what is, can make a difference, even if that's happening first. So from that perspective, I gave you this paper. Again, this goes to the details of all the intricacies, how cancer medicine pricing, these therapies are developed, their pricing is, set, the policy is set, who and how they are made available, and how is, given, and Dan is a radiation oncologist, so I'll give an example, for example, most of the, developing countries have very, small number of, setup where you can give the therapy, radiation therapy. The number of linear accelerators are a very handful and the number of patients who are eligible to receive some radiation therapy, but the amount of machine times you have is only a fraction of it. So then what do you do? So now you know that, okay, this particular stage of breast cancer, this particular stage of this cancer, if you can give this radiation therapy, which is already well known, just because, but the amount of dose and, you have to give to a type of, the duration, you just have too many patients who will have given, compared to the machines that you have available. So now what do you do? So now then those therapy, radiation oncologists, they're thinking, okay, maybe you will give half the dose, half the duration. Maybe instead of giving 2 cycles, give 1 cycle and see how it works. Similarly, some of the this chemotherapy, maybe we'll give them half the dose, or maybe give 2 cycles instead of 1 cycle. Those sort of compromises are being done. But again, sometimes those are done even without knowing whether those are actually, the therapy clinical trial based on which the result is known based on a certain dose and duration, not have the dose unless you know it. So maybe those research needs to be done in those setting, in a developing country setting. It doesn't matter here in the US, but in that setting, it needs to be done. Okay, this therapy works. Let's see if we do the half of that dose, half the duration, does it make a difference? If it does, we'll do it. If not, they shouldn't bother even doing that, because there's no point in, rather than consider, okay, let's give the most severe of those patients, give the full dose, and the less severest one, let's not do it at all, instead of giving the half the dose of the radiation. I'm just giving an example about this. So maybe those type of research needs to be done in those, in a resource poor setting, instead of doing something else that they cannot do anyway, or that has very little implications. So anyway, this paper again goes many of the components of how drug pricings are set, how that could be made difference and different setting, and I will not go into that again. I will pause here again quickly in case you have any question. Otherwise, I will see if I take a few more minutes to talk about at least one example of my research. Any question here at this stage?
So there's one question from Andrew. Andrew, do you want to read your question out loud? Or I can read it out loud. So he asks, how high or low is foreign investment in LDCs for cancer?
He's unmuted, Aviva.
Well, I'm sorry.
My mistake. No, it's good. I was wondering what's the degree to which the international aid community is investing in, I guess, progress on cancer in low development countries compared to conditions like malaria?
Yeah, good question. As I showed you before, up until now, cancer has received less attention just because it's not visible, and it doesn't, so it's much less compared to TB, AIDS, and malaria. Again, those needs to be tackled for obvious reason, but cancer has been less under the radar, and it's only coming up in the radar now. So that's what I would say, based on my knowledge. Does that answer or your question? Or that all I know at this stage?
Yep. Thank you.
Okay. Okay. So this paper will give you an idea of how cancer medicine is, and all this intricacy about policy, cost, availability, politics, everything related to the and the economics of it, that because a rare cancer, only a handful of number of patients who can receive the cancer, it costs so much money to develop. So it's not even, the cost of those drugs for the pharmaceutical company, when they invest billions of dollars to develop a therapy, and if only a small number of patients they can sell those, then obviously, even if everything else is said, then the cost of that has to be high enough so that it's worth it. Otherwise, they will not develop those drugs. So there's many factors are related to that, and you have to pay attention to those as you talk about it. So I will talk about maybe, I don't know that I can have time to go into too much of those, but maybe I will just give the introduction, and then so when you do global health research, which I do a lot of it, half of my research is involved in the global health setting research project. So I wanted to make one point. In addition to everything I said, I want to make one point that of course there's challenges of global health research, no matter whether it's cancer or anything. And as I listed them, some of the left side. So those are all well known. I do not want to repeat, but I want to make the point on the right side of the points that often are not appreciated by, and you may hear, you may not hear that often, but I want to make that sure that you hear that. And there are a lot of opportunities of doing research in the global health setting, and I listed here a few of those. Obviously, if you can get the right setting, the cost of doing research for a unit amount of money can do a much larger study with much larger amount of valid, good quality data. And so the result that you can get from those even often can be even reverse translated to back in the high income countries. So if the research can be done in in an innovative way, something you can do in a global health setting that you cannot even do it here. So, and there are examples of that. And I don't know that I will have time to do that. And then I give you some examples, before why that is the case. Sometimes you can get, obviously for cost reason, large number of population, you can study certain thing. The motivation, acceptance, and cooperation, there are initial hurdles to set those up, but once you go through that initial hurdles, then you see the efficiency of doing those research could be very, very different. So I do a lot of research here in Chicago. I do research in Southside Chicago in the population, in the medical center, and I do in global health setting also. And I can give you an example. Certain thing I can do much better in a global health setting, in a much quicker, produce much faster results than what I can do it here in the Chicago, in this even despite that, and vice versa. So you just have to see which one, do the right one. And similarly, there are the impact. You can see that for global health, and depending on whether do you, certain type of research, do you want to make an impact on, obviously every life matters, but if you want to make a difference in the one life difference is one life versus maybe 1,000 life, some of those aspects also you can depending on the setting, you can those factors also play a role there. So I will just give you one example here. So one of the research setting that I do here in South Asia, that we have, I'm just setting the exact example here, and I will not go, I will not have time to go into detail. So we have a population we chose. I started 20 years ago. In one part of South Asia, chose one area where there is 500,000 people live, and we have chose that area, and of that 500,000 people, we have selected 35,000 people and made a longitudinal cohort, and there are 70,000 children, and we created a very comprehensive biobank of those cohort and their children, and we have been following them over time for the last 20 years and ascertaining a whole range of biological, clinical, and parameters over time. And then on the right side, I'm showing the type of research that I have, me and my other colleagues have been doing there. Of course, epidemiologic studies, genomic studies, intervention studies, randomized clinical trial for including cancer, clinical trial we are doing there, community intervention trial, as well as health economics and social science and health services research in that setting. And what we do have, I want to show this, we have this Chicago Research Bangladesh. That's an affiliate of University of Chicago. It's an international NGO incorporated in Chicago, but also incorporated in Bangladesh. That is that component. We have a community hospital, this 6-story building, as you can see, in that middle of that area where the 500,000 people live. We provide them free and subsidized healthcare. We have our own electronic medical record system that homegrown locally, cheap, that can track every, there are over 200 patients come to that clinic every day, and there's some basic primary care and selected secondary and tertiary care, healthcare we provide. And those 35,000 members and their family members receiving this care for the last 20 years. So we have this population health research laboratory, and through which we are doing a whole set of research from basic public health to very modern genomic large-scale studies to even digital health, artificial intelligence-driven healthcare testing models, and some research that we are doing. So I don't have time to go into the examples of those. So, but my point of showing that here, if you, with careful planning and investment and tenacity, and if you can think of a long-term effort instead of going in one area and doing some quick short-term cross-sectional work, you can do certain things. But if you can invest and take a long-term goal, you can do much more in-depth, high-quality research than otherwise. And that's the path I took. I chose to work, and initial part of my career, I work in many different countries, but then I chose to work in one area and devote all my energy in one place and to do everything that we have been doing in the last 20, 25 years. So I will stop here because I see that time is past. It's already 5:30, so thank you for your attention. If some of those details, I would be happy to, in another capacity, some of you contact me. I'm happy to discuss specific aspect of some of these, but I will stop here.